Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome back to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I am your host, Jonna Amiel, and joining me is my co-host, an expert faculty and expert witness, which sounds like, that kind of sounds scary. It sounds like you need to be in like witness protection program now that I say that out loud. Dr. Sally Miller. Dr. Miller, welcome. Thank you for joining me as always.
Oh, thank you for having me as always.
Absolutely. Now, if you're just tuning into this podcast for the first time, we are actually going to talk about real medical malpractice cases, right? So these are actual cases that Dr. Miller has served on. And we're going to talk about these cases in the light of, listen, mistakes happen, right? We know as providers, as practitioners, as clinicians, that things happen and we don't always do the right things, or the outcomes don't always turn out in the way that we expected, right? So these stories, not only are they real cases, but really interesting and really an opportunity for us as healthcare providers and professionals to learn from when things go wrong, quite honestly, right? To learn from that and to think about, what are the things that we might be able to do different? What are the things that we should encourage ourselves and our staff, right? And our colleagues, our peers to do, right? Now, it's funny because I have a friend, I'll talk to Dr. Miller, I didn't tell you this. I have a friend who said that she saw this podcast come across, right, the whatever podcast platforms that she listens to. And she's an NP. And she reached out and said, I'm about to go on shift. Before I do, should I listen to this or should I not listen to this? How much is this going to scare me tonight? But you know what? It was a really good conversation because although those things are scary, right? And we kind of feel like, oh my gosh, we never want this to happen to me. We know we're not exempt. And more than anything, it really is an opportunity to learn, right? I think it's an opportunity to learn. Do you agree with that?
Oh, 100%. So often I review these cases and I think, oh man, that could have been me. That could have been me. That just an innocent miss. You don't think of something or you do it and forget to write it down. Oh yeah, 100%. It can happen to any of us anytime.
Yeah. And easy things, just as you mentioned just now, saying you forget to write it down, something like documentation, like documenting a thing, right, could actually lead to a pretty bad outcome. So these are really good. I think it's a good reminder of all the things we learned in school, all the things we learned when we were little tiny practitioners or little tiny nurses right before we got out there. But there's a real reason to that. So when you're ready, let's get into the case
I'm ready.
that you got for us today. And as you listen along, folks, one thing we like to remind you of is try to kind of pick up the things that you are finding I think that may have been a miss. Oh, that may have been a different opportunity we could have done. And it's also pretty interesting to try to guess, if you will, what side Dr. Sally Miller was actually serving on, during these cases. So I'm ready when you are.
I try to present the case in a way that you can't tell what side retained me, although I realize in retrospect, you probably can. And so something I'm going to do a little bit differently,
Okay,
easy for me
great.
to say. I'm going to do a little bit differently for today is literally have my notes right in front of me so I can read the relevant things to you directly from the notes. There's that 6 degrees of separation. There's a big difference between me telling you my impression of a thing versus me telling you verbatim exactly what the nurse practitioner had in front of him or her when working. So this case,
Okay.
and I encourage everybody who's listening, you please have to come back and listen to the other podcast as well, because it's really interesting how you can have the same basic principle housed in 2 different clinical circumstances with different types of people. And it's the same basic thing, but it can be perceived very differently by judges and juries depending on the people involved and the rest of the circumstances. And so this first case, I will tell you, this is a really interesting one, and actually it made it all the way to the New Jersey Court of Appeals, and there was a public
Oh,
there's a public record available of the appellate court, and it's really kind of funny and it's really interesting. So if anybody's interested in reading that, just reach out to us. Sally.miller@colibrigroup.com. Anybody can do that, and I'm happy to share the link with you. But here's the story for people that don't want to go into the whole appellate
all right.
position, publication, or whatever it is I'm trying to say. So the thing here, the question here is about standard of care, which is what really most malpractice cases are about. Did the APRN deviate from the standard of care or not? And remember that the standard of care in legal jargon isn't a guideline or anything like that. It's in legal jargon, it's what the person of the same training, experience, and education would do in the same or similar circumstances.
Right.
So, okay, with that said, here we go. So the patient she had just turned 58. She was a 58-year-old woman, and she had been a patient of this particular outpatient practice for over 10 years. There was documentation in the chart going back to 10 years prior, all the way back to the days of handwritten records that I was trying to tease through. And so, so she had been seeing this practice since she was in her mid 40s. And, the usual things, she had several visits over the years, a lot of times cough, cold, upper respiratory, GI, nausea, vomiting, the occasional menopausal symptoms, a fairly typical chart for a woman of that age. No significant medical history, no significant cardiac events or anything like that. And so on this date in question, she presents to the APRN, who she has seen many times in the past, and she presents with upper respiratory symptoms. So I'm not going to read the entire chart to you, but some of the pertinent stuff here, I can make it visible on my screen. So the documentation says she presented with upper respiratory infection. Recent symptoms include postnasal drip, scratchy throat, and cough was dry, hacking, now moist. The condition is acute. I mean, this sounds like a click and pick, click and
Yeah.
click electronic
Yeah.
medical record. Symptoms began 1 week ago. Initially 1 week ago, cough. Initial symptoms 1 week ago, cough 4 days. So in other words, she started the postnasal drip, the scratchy throat, that kind of stuff 1 week ago, and then 4 days ago, she developed the cough. The severity is moderate. Symptoms are daily during day and evening. Current medications include antihistamines, decongestants, and a cough suppressant. The problem is exacerbated by activity and position change. Pertinent findings include adequate urine output, cough, postnasal drip, denies chills, denies fever, and denies sinus pain. The APRN acknowledges in a click and pick that she has reviewed the documented medical history, medications, drug allergies. The only thing pertinent was that the patient had an allergy to sulfa. She is allergic to several antibiotics. She was allergic to sulfa, clindamycin, and quinolones. She also, interestingly, had a remote history of C. diff. So when somebody's had C. diff, you're always a little bit hesitant with the antibiotic thing anyway,
Yeah.
because broad spectrum antibiotics and C. diff. So that was what the NP included in her note that she reviewed, these things of which she was aware. The patient denied fever. The vital signs were significant. Let's see. She was 5'5", 164 pounds. Her temp was 99.0 orally, and her blood pressure was 130/80. On physical examination, she appeared well nourished, well developed, etc. The NP documented inacute distress due to persistent cough. On examination of the throat, there was clear postnasal drainage, otherwise benign. There were no anterior or posterior cervical nodes. The lungs auscultated as clear bilaterally. The diagnosis was upper respiratory infection, and the patient was treated with promethazine, cough syrup with codeine, which of course now opioids are evil, but this was several years ago, and it was very common to use a cough suppressant with
Oh,
codeine in it,
yeah.
especially in someone like this who she documented she's in acute distress because of the persistent nature of the cough. So the patient was instructed to rest, drink plenty of fluids, use her cough medication as directed since over-the-counter meds had not been helpful, and returned to clinic not improving over the next 2 to 3 days. So that's it. That's the story. Sounds pretty typical, right?
It sounds pretty
So
like urgent care visit.
yeah. So I will
Yeah.
ask your audience to give some thoughts to what what conclusion you would draw with that information in front of you. And, and be careful to not be thinking, well, what about this? What if that? What if this? What if that? We can't think that way. We can only look at the information that the NP had on the day of the visit. And that's what she had. The patient was longstanding of the practice. She had had over the years relatively regular intervals of upper respiratory infection, the occasional other, acute complaint like nausea, vomiting, etc., some menopausal symptoms, and that was it. She did have numerous antibiotic allergies, and she had a history of C. diff. And this is what the NP documented in the note that she reviewed, and that's why I'm highlighting it. Not that we necessarily, any of us would go back to a note 10 years ago and zoom in on a certain thing, but
Right.
for whatever reason, that's what this NP ordered. Okay, so that's that. So then the next thing that happens, that was on I can tell you the date, it's just so long ago and so many years it doesn't matter. We'll say that was on the 28th, that was on the 28th of the month, right? So that was on the 28th of a month with 31 days. So let's see, 28, 29, 30, 31, 1, 2, 3. I had to count on my fingers like the academic that I am. So 6 days later, the patient comes back to the practice. And now it just so happens it's the luck of the draw that she is seen by the physician on that day. So she comes in, he documents, presents with upper respiratory infection. Recent symptoms include nasal congestion, nasal discharge, postnasal drip, scratchy throat, hoarseness, ear pain and pressure, sinus pain or pressure, productive cough, shortness of breath, wheezing, and fever to 102.5 the last few days. Secretions are yellow. Yeah, so now she's got a fever. Definitely things are changing. She had been on Mucinex, Tylenol, Advil, Aleve, and the cough suppressant. She woke up this morning on this 6th day at 4 a.m. with difficulty breathing until she coughed up a big mucus plug. So he too acknowledges her current medication of promethazine with codeine. He acknowledges her medication allergies, the various antibiotic allergies, etc. As he goes through the review of systems, he does note the presence of fatigue and fever, but denies insomnia, night sweats, unplanned weight change. No, pretty much everything else in the constitutional review is negative. He acknowledges the cough and the dyspnea. Patient has no history of asthma or any respiratory phenomenon. In the office today, she has a temp of 99.4. Her blood pressure is 120 over 76, and for reasons unknown, there is no pulse documented. He documents that the ear, nose, and throat exam actually looks totally benign. The respiratory auscultation, he says, auscultation overall breath sounds are clear bilaterally. Overall, no retractions, normal rate, rhythm, etc. So a normal respiratory auscultation, normal cardiac auscultation, diagnosis acute URI, cough, fever not otherwise specified. He orders a chest x-ray and a CBC, probably because the patient A is not resolving and B now has a fever and
Right.
is having some shortness of breath and coughed up this big mucus plug. So would check chest x-ray, yeah, because of new fever and continuing off. If normal, await labs. May well still be viral. Others have had a prolonged course like this. He encourages rest, fluids, Tylenol, all that good stuff. Call if the fever is greater than 101, persists, or the cough becomes more productive, or symptoms worsen. So sends her home. That was on the 3rd of the month. And again, so I would ask your audience, sound reasonable, sound not reasonable. The chest x-ray was read as negative. There was
Okay.
it was negative for consolidation. So no viral consolidation, no bacterial consolidation. Viral pneumonia and bacterial pneumonia, they look different on an x-ray, but this one read as negative. They also had both noted in their note that she had had her flu shot 2 months prior. I meant to mention that and I did not. Her CBC was normal. The differential was within normal limits. There was no elevation of neutrophils or lymphocytes or anything to suggest that there was a bacterial or infectious process. So
Okay.
guess what happens next? Oh, if only we had background music. Mm, 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 or something like
Dun,
that.
dun, dun.
I'm sure obviously something happened next because we wouldn't be here talking about it if something
Right.
hadn't happened next. Well, what happened next was another 6-day interval for, I don't know why. I guess it's like things are happening in 6 days here. In 6 more days, on the 9th of the month, the patient called an ambulance. Her husband called an ambulance, took her to the emergency department because she woke up in the middle of the night and she couldn't breathe. So now the history that she gives in the emergency room when she is being evaluated there is, she says, about 3 weeks ago, after returning from a trip by train, she noted stinging in her eyes. This was followed by onset of cough that was coming and paroxysms. I don't think I have ever had a patient tell me they had a paroxysm of cough.
She used that
So,
word?
and I don't think she did, but that's what was noted, not documented in the note. And I say that a little tongue in cheek, but it is kind of an example of how, every note is somebody's interpretation of it, unless you're
Yeah.
quoting the patient. So anyway, the cough was coming in paroxysms and was associated with a popping noise. Now the patient probably did say that, who knows? But the cough. So the cough was really the focus of this HPI. The cough has been present constantly for the last 2 weeks. At times, it has been productive of thick green sputum, intermittent fevers to 103, heavy sensation in her chest, no radiation. She has had some nausea and vomiting and diarrhea and et cetera, et cetera, et cetera. She was in the hospital, and it was a big like well-known tertiary care center. So they were aggressive in their evaluation. And guess what their evaluation revealed? Do you want to
What?
guess? She had pertussis. She had
What?
pertussis. She had Bordetella pertussis. I know, right? So then she had pertussis and apparently developed a secondary pneumonia as a consequence. Pertussis causes inflammation. I mean, I don't know. I don't know that I really don't know that it causes pneumonia in its own right, but maybe it does. But the inflammation of the airways renders the patient very vulnerable to secondary infection, whether it's viral or like an atypical pneumonia or something. But anyway, I mean, even most emergency rooms that I'm familiar with would not have done this aggressive workup. But it just so happened that, I mean, she was seen by infectious diseases and everything. Either her presentation was that bad, or like I said, it's a major teaching university medical center, and they do tend to be a little bit more aggressive. Anywho, bottom line is she has pertussis. So now, and she's sick. She's really sick at this point. She is in the hospital. I think ultimately she had to be intubated briefly. She
Oh my gosh.
she recovered. She got over it. She was treated. She recovered. She was rehabbed, and she was discharged to home. So then there is this. I'm looking for these notes here. That again, I don't want to be. I want to tell you my impression. I want to read you exactly how it was reported in the documentation. So she was in the hospital for, I think, maybe 2 weeks. She was hospitalized, briefly intubated, and then had to recover. And I mean, when you can't breathe, of course, it's pretty scary, and it's a slow, steady road back. But she
For
was
sure.
discharged to home. So this would be like in February. By February for sure of that year, she was home. And in May of that year, another physician consultant documented that she appeared well and without symptoms. So she was recovered and going back to work. So
Okay.
she filed a lawsuit against the nurse practitioner and the physician, basically saying they should have tested her. They should have been suspicious for pertussis and tested and treated it. And what she claims as consequences of this, what she asserts is a deviation of standard of care, I have a list. I kid you not, 4 8.5 by 11 single-spaced pages of bullet points of damages as a consequence of this. Incessant violent coughing for months, can't sleep, keeping others awake with the loud coughing, tired and fatigued all day, excessive dryness in the nose, mouth, and throat, and needed assistance to be clothed, needed assistance to walk, couldn't eat or swallow from February till May, had to be fed sips of Ensure, still cannot
Really?
eat the skins on the fruits, lost 25 pounds in the process. I mean, and I'm just picking out a few of the obvious ones here. Can't bend down, reach up, or lift. Still has an issue with GERD. inability to clean the house, vacuum, um, took weeks to walk to the corner. I'm just scrolling through pages upon pages of assertions here. So the patient initially did not hire an attorney. Her husband chose to represent them in court. And
He's an attorney?
no, he's not an attorney. And we all have the right to represent ourselves in court. You don't have to have an attorney. It's just that
True.
there are so many, there's so many procedural issues that you could have a good case and blow it because you don't follow a procedure and it gets dismissed. So I mean, I don't know for sure, but I suspect that it was perhaps the husband that initially assembled those 4 pages of single-spaced consequences to try to substantiate, and was suing. The amount suing for was $60,000, which I mean, it's usually a lot more than that people are looking for. Maybe that's why they didn't have an attorney. Anyway, things kept getting dismissed because he wasn't making the case properly. So he finally did find a plaintiff's attorney to take this to court. And so they did, they got their day, they got started in court. So as soon as they finally got into a courtroom, the defense attorney, the one that hired me, moved to have it dismissed based on the fact that there was no evidence that there was a deviation from standard of care. And so the plaintiff's attorney, the patient's attorney, found an infectious disease expert that wrote a report and testified the nature of pertussis and how it does present the way that the patient described, and had it been treated earlier, she may not have suffered all these consequences. This one expert, but when asked by the judge, couldn't really produce any supporting documentation that not testing for it was a deviation of the standard of care. This case went on for years. The events happened in 2012. The patient herself actually died, I think, in 2018 of something
Oh
totally
my
unrelated,
gosh.
completely unrelated to these events. The patient,
Okay.
she
Okay.
died, but her husband continued the case. And finally, it was in 2019. So, the court held that there was not enough evidence to support a deviation of standard of care. And so then they appealed it to the appellate court in New Jersey, and the appellate court basically said the same thing. And they listed out everything they were looking at. So it's really interesting as you read it, how they just sort of teased it apart. But the bottom line is, yeah, she had pertussis. Okay, she had pertussis. Pertussis, I think the stats for pertussis are something like 0.7% of the population. And it's much more likely in kids and adolescents. Yes,
Yeah.
adults can get it, just like we could walk outside and a tree could fall on our head, but the likelihood of it is very, very limited. So the issue, and there was an NP expert that was hired by the plaintiff who supported the position and said that it was a deviation of the standard of care not to consider pertussis as the differential diagnosis. And it made me sad actually to read that. I hope that person reads the opinion of the appellate court because it's just so clear. But the bottom line is, we are told over and over again in school, in the evidence. I mean, all sorts of evidence that's published by the Infectious Disease Society of America, the American Thoracic Society, American Academy of Family Physicians. I mean, it's all about don't use antibiotics inappropriately. Let's be judicious. The overwhelming majority of upper respiratory symptoms are transient viral URIs. And so this person documented it appropriately, treated it appropriately, especially for someone with all of those allergies to antibiotics. I mean, listen, there was a time, and even, back then, because this happened about 10 years ago, there were still plenty of people that just gave out a Z-Pack to people that coughed,
Oh
just
yeah.
because patients want an antibiotic and, a Z-Pack was easy to write,
Oh yeah.
Z-P-A-K, number 1, as-der. I mean, it was brilliant marketing on the part of the Z-Pack people. But to assert that she should have been empirically given antibiotics is just like absolutely flies in the face of everything that is asserted for us in these last years. And so, I mean, it was helpful that the case was not well presented. I mean, it never even got very far, but the judge, both the initial judge and the appellate judges were very clear that there just wasn't enough evidence. And yes, acknowledge she did have pertussis, but that's not the issue. Lots of times in plaintiffs' cases, they look they make a judgment call based on the outcome. I mean, it's Monday morning quarterbacking, hindsight is 2020. Of course, if you know she developed pertussis, you would say, oh, dang, wish I had considered that in my differential. But we didn't know. I mean, the MP didn't know she had pertussis. She knew that she had 1 week's worth of symptoms that included postnasal drip and runny nose and scratchy throat and cough and no fever, et cetera, et cetera. And then even 6 days later, when the physician saw the patient and she had a temp and the physician did an x-ray and did a white blood cell differential, I mean, there was still nothing to support it. So, I mean, it was just very crystal clear that there was no deviation from standard of care. And, thankfully that was acknowledged and the motion was dismissed before it even actually went to be, presented as a case in court.
That is really interesting. And, as you're talking about pertussis, I would have never, ever guessed it. I have really only seen pertussis in kids, just in the pediatric community. So to be quite honest, I don't even know. It's never even a thought. If I'm telling the truth, it's never even a thought when when there's a sick adult, roaming around. But, with that said, I know how this goes for peds, but having a missed diagnosis of pertussis, can you talk to us about, well, what's the treatment and the journey of pertussis anyway? I don't know it, and I could be wrong. I don't know it to be something that really turns into be like a fatal thing for most adults.
It's, I haven't seen it enough, and I don't even think it's around enough or well documented enough to have a good understanding
Yeah.
of the fatality in adults. And mind you, this lady, her death had nothing to do with it. She had pneumonia. She was in the hospital. I'm sure it was unpleasant. I'm sure being intubated was unpleasant. And then she got better and she went home. And these assertions about having to be fed and clothed. There are certainly times when people are really hypoxic for a long time and they do need to be rehabbed. And I don't know how much of it is very literal or perhaps how much of it might have been, subjective interpretation. You know what I'm trying to say here
Right.
in the most delicate possible terms.
Absolutely.
But the thing about pertussis is that you just don't think of it in adults. Now, there was a time, some years ago, I think it was after these events, but probably while it was in trial, that there was a little bit of attention to the upsurge of pertussis in the population. Again, the real concern being kids, the real concern being peds. But this is why the CDC recommends that every adult have at least one Tdap in adulthood, right? It's the acellular pertussis piece of it. So, but it's to protect exposed children. It's really to protect being around children. So there is an awareness of a bit of a resurgence in it, but you think of it mostly in children, and you don't typically think of it as a fatal condition. And even then, like antibiotic therapy, it's really controversial if it even makes much of a difference or not. The primary reason to take antibiotics is to prevent the spread, to prevent communicability of the pertussis, not so much to protect the patient or improve the patient's outcome. I mean, certainly there is some literature that suggests outcomes can be better because the duration might be shorter, but it's really, a little kind of iffy there. But I mean, the point is it's really not in anybody's differential except maybe after you watch this episode and then think,
Right.
because there is this trajectory of pertussis where initially it does look like a regular old URI. It's referred to as the catarrhal stage. In the first week or so of infectivity, it just looks like a regular URI. That whooping cough, for which it is
Yeah.
named, that comes a
Yeah.
little bit later. I've only ever seen it once, even in a child. Only once in my career have I knowingly encountered pertussis, and it was in like a 9 or a 10-month-old baby. And the cough is really distinct. Like it is a really
Yes.
profound. You hear it, and go, what? But
Yes.
but there is that phase before that where it just looks like garden variety URI. And I mean, let's face it, unless index of suspicion is really high, like unless there was a potential exposure, Nobody's going to think of that. Now, interestingly, in the history of present illness that was reported in the emergency room chart, the last recorded history before she was
Yeah.
diagnosed and treated, that business of being on a train and surrounded by people who are coughing clearly is meant to represent a history that was characterized by potential exposure. And maybe she really just didn't think about that in the first office visit because maybe she didn't think it was significant because she just thought she had a URI. So it's very possible that when she saw the MP on the 28th, she didn't think to mention a bus ride a few weeks ago, or rather a train ride a few weeks ago. But then as time went on and symptoms worsened, and an infectious disease team, because it was a teaching hospital, was evaluating her and would undoubtedly ask very pointed questions like, well, have you been exposed to anybody with respiratory illness? Have you been in close quarters? That kind of thing, and
Right.
helped her elicit it. But it doesn't appear even that the NP knew it, and it wouldn't have made any difference, I'm sure, if she did. I mean, you're much more likely to get a URI on the bus from people coughing than you are to get pertussis. So just the absurdity of suggesting that the NP should have considered pertussis as a differential diagnosis in, this like 57, 58-year-old woman who was having upper respiratory symptoms is just crazy. But I'll tell you what, one of the other ironies is that the treatment for pertussis is a macrolide. It's like a Z-Pak. So
Oh my
I
gosh.
know, right? So like
Oh
a
my
Z-Pak,
gosh.
erythromycin, or Biaxin. So the Z-Pak that we've like been spending years trying to convince people not to give out like
Right.
candy. I mean,
Stop
now
doing
I
it.
know, I know. I mean, listen, like I said, I learned something from every case I look at. So I can't say that I don't have a slightly more suspicious eye. And if I'm on the fence a little bit, might more with the cough, more with something that looks like an acute bronchitis, cough, cough, cough. It's always in the back of
Yeah,
my mind. But yep. So
that
that's
is
but in
really
the end, it was
interesting.
just a simple assertion of deviation from standard of care, and it's just crystal clear that there was not.
Yeah. Yeah, I mean, certainly stinks for the patient. It sounds like she had a rough time, a rough go at it. That's not pleasant at all. I would have absolutely never guessed pertussis, not even with the history of being around, potentially sick people that are contagious. I wow, that's really interesting. But with that said, too, for sure, there is at least one person in the audience right now going, "Oh my gosh, I have to test for every single thing when they come in with a cough." What is your advice to that NP right now that's like, "All right, I'm whipping out my list of all the possible things it could be."
Like this is exactly what we don't want to do. This is exactly what we are taught not to do. I mean that's referred to as shotgunning. And
Yeah,
30, 40 years ago, that is what you did. It was like sort of a defense mechanism against malpractice litigation. Just test for every
really.
conceivable thing. And then over the years, we are strongly encouraged not to do that. Now, it is reasonable to do a history. It is reasonable to do a good history and maybe take a minute to, I mean, no, but I wouldn't have thought of this before, and I don't think anybody would have thought of it before.
No.
But having seen something like this happen, as much to, help the patient as to protect us from litigation, when you're seeing somebody with a URI, it's maybe worth one or two questions about and I know this sounds odd, but any chance you've been exposed to pertussis? Or have you ever had your pertussis vaccine?
That's good.
Or
That's good.
have you been in an environment where like lots of crowds where lots of people are coughing? And I mean, if you can check those off, no, I would certainly not want everybody to run out and start testing for pertussis immune globulin.
Yeah.
It's I think well, I mean, really interesting is that any attorney took this and that any witness would assert that there was a deviation of standard of care.
Man, and boy, well, I tell you what, Z-Pak is happy for this conversation.
I know all of a sudden we're going to see an upsurge in the prescribing of Z-Pak. No, no, please
Wow.
don't. Please don't.
This was very interesting. Dr. Miller, thank you so much for this story. This was a really good lesson. And that was tricky. And I am not happy, of course, for the patient's outcome. I understand that she died unrelated, but I
Yeah.
am happy that this turned out to not be something that, truly, truly was such a fatal, life changing thing for this client.
I mean, sometimes we do everything right, we can do everything right and it still goes wrong.
Yeah. Yeah. This was great. Thank you so much. Thank you all for listening to the story. We hope that you found it interesting and learned some things from this. And if you enjoyed this podcast, check out the others that we got going on. We hope you'll join us next time for our next episode of Scrubs and Subpoenas. Goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.